Spine is a very important organ of our body. As you know, spinal cord is actually surrounded by the vertebral bodies and form a vertebral column, and then there is inside is called a spinal cord, which exits in form of nerve roots exiting towards and going towards different muscles. The spinal cord infections or spinal infections can be very debilitating for the patients. If they start involving the roots or the spinal cord itself, they can cause progressive paraplegia, neurological compromise, which may eventually lead to paraplegia or even the quadriplegia as well. Spinal cord infections can be classified in two basic types, which are mainly the pyogenic and the non-pyogenic. Now, pyogenic infections include mainly the called as the bacterial infection. And why we classify broadly into types? Because there all other non-bacterial infections can be classified as non-pyogenic. And among the bacteria, the most common form is actually the bacterial is the Staph aureus. Staph aureus and Staph epidermidis still constitutes the majority or bulk of the pyogenic vertebral osteomyelitis, or called as adult pyogenic vertebral osteomyelitis. Other causes could be Pseudomonas, which is usually common in IV drug abusers, and the rare causes could be as well, such as sickle cell disease. Patients may have Salmonella infections or Salmonella pyogenic osteomyelitis of the vertebra as well. Therefore, the most common to remember is the Staph, but the other rare causes could be the Pseudomonas as well as the Salmonella species as well. Among the non-pyogenic, the most common is actually the tuberculosis. It's basically tuberculosis has been associated with third world countries. Mostly it's endemic in South Asia and Southeast Asia, but now there's a resurgence in the first world as well, and that is mainly because of the HIV, because the patients over there have become more immunocompromised, and this immunocompromised state they're more prone towards the tuberculosis infection. Other less common causes of the non-pyogenic osteomyelitis include such as brucella, which is usually common with brucellosis caused by the exodus tick bite. Then there is aspergillus infection. This is a fungal form of infection which is usually very rare, but it can be associated with osteomyelitis. Or other fungal which may be endemic in different parts of the world may be causing the osteomyelitis, but that does not happen unless the patient is immunocompromised. Other causes could be parasites as well, especially in third world countries where there is a lot of waterborne diseases. The parasites could be one of the cause of the spinal infection as well. Now, if you see the spinal infection, there are three basic routes. The most common route is actually the hematogenous spread. When we call it hematogenous, means they are actually the pathogens or the offending organism is carried via bloodborne, may have infected some other part, or they may have entered into this through the skin. For example, if it's Staph epidermidis, this may involve, for example, infection may be spreading due to the skin cuts or something like due to penetration of the skin. For example, if somebody is a football player and usually gets staph burns, and then this may result in Staph aureus infection, because once the skin breach occurs, there may be associated with increased Staph aureus or epidermis infection. Now, once the organism has penetrated into the bloodstream, then it can go anywhere. And if the patient happens to be immunocompromised or on steroids or on taking due to any other autoimmune disease, then the patient can have this sort of a pyogenic infection secondary to hematogenous spread. The second most common is direct external inoculation. Although with trauma this is usually rare, because there is very less likely chance of direct inoculation during a penetrating trauma. But for example, in surgical cases, or if the patient has already undergone some form of spinal surgery, then this route actually has an increased incidence as compared to the hematogenous spread, because the skin breach has already been done iatrogenically by surgical exposure. The third is from the contagious tissues, like patient may have an epidural abscess, and as it is around above the epidural, then as it descends down and further aggravates, and it may involve the vertebral column. It may involve the different parts of the vertebral body like body, lamina, pedicle, or may even involve into the spinal cord canal and may lead to some form of neurological compromise as well. Now, when we talk about the spinal infection, the most common it is always the risk factors. Now, when we are mentioning risk factors, we include both the pyogenic as well as the non-pyogenic, or as well as the tuberculous. As I told you, there has been a resurgence in the first world, especially the developed world, of tuberculosis. Why? Because of the HIV and loss of immunity in the patient population. The most common, if it's direct inoculation, could be due to the previous spine surgery, because there has been a breach of the soft tissue. The skin has been breached, and there may be direct inoculation or spread from one. A patient may get that sort of a problem once the patient is out of hospital, and then the patient may involve the skin incision may get infected and eventually become again lead to some form of spinal infection as well. Then some of the other causes includes diabetes. Now, diabetes also causes immunocompromised state, and due to immunocompromised state, there is always an increase in incidence of atypical infections such as tuberculosis, fungal, and these infections, which may be more common in the diabetic population as compared to the pyogenic infection. Then chronic renal failure as well. This also puts patient under stress and into a state of a immunocompromised state, which may lead to increased pyogenic infection. Septicemia, this is actually due to then there is a lot of septic load in the blood. This may, by hematogenous spread, may spread toward the spinal and may also be causing the spinal osteomyelitis or infection as well. Then protein malnutrition, if the patient, for example, suffering from undernourishment or protein malnutrition, patient is not good enough to build a response, immune response against infection. Therefore, these patients are increased at a high risk of susceptibility towards spinal infection, especially the atypical one like tuberculosis, parasitic, and fungal. Then IV drug abuse. IV drug abuse is one of the most common cause of the resurgence of tuberculosis in the first world, because especially the HIV has been associated with IV drug abuse, and these patients who are usually IV drug abusers may have a pseudomonas infection, or may, due to the HIV, may have a tuberculous infection as well. And IV drug abuse users are very closely related to the HIV as well. And those who usually IV drug abuser, they may have HIV as well, and may eventually be immunocompromised, leading to a lot of spinal infection. Other causes is liver cirrhosis. Certain organs damage, such as liver, kidney, they may actually those factors, immune factors which are being synthesized in the liver, are not done properly. As a result, the patients are more immunocompromised and more predisposed toward the spinal infection. Now, how to assess a spinal infection? That with any disease, the first and foremost thing is always the history and examination. You will always get a history. If that depends whether it's an acute pyogenic osteomyelitis, or is it a chronic non-pyogenic type of an osteomyelitis, which is most commonly caused by tuberculous or all this as well. So there will either be an acute symptoms which may be present over 2 to 3 weeks, or they may have aggravated quite quickly over the last 7 to 10 days, which may include back pain, which may include malaise, which may include pain with the movement, especially the forward and backward bending of the movements, something like that. This all can be pathognomic of some form of infection. Then what you need to do is you can do the examination. A neurological examination is important to assess whether is there any neurological compromise or not, or is there any progressive neurological loss as well or not. Because if there is already a present neurological compromise, this means the canal may be very much compromised, and there's something which we need to do urgently. But for example, if there is no clinical loss at the time of presentation, but patient develops a progressive loss over 2 to 3 days despite the use of antibiotics, now that means the patient condition is actually worsening. So what we need to do is we need to intervene early so that we can save the spinal cord of the patient. Therefore, initial assessment is always the clinical. If this may be associated in acute cases, there may be associated with fever spikes. You may have some form of a risk factor available as well. Patient may be diabetic, patient may have HIV, patient may have a previous spine surgery, patient may be malnourished. So there would be some form of a risk factor. In presence of risk factor, you are suspecting infection here. Then you must think of on examination you must rule out neurological compromise, and once you rule out whether there is or there is no neurological compromise, then we go for radiographic evidence or the other laboratory investigations which we need to confirm our diagnosis. And then with any infection, the first and foremost is always the blood CP. You, in acute cases, you may have to look at the TLC levels, you may have to look at the ESR level, you may have to go for a CRP value which may be very high, and usually it's even in case of tuberculosis there may be TLC may be normal, but there will be definitely some form of a lymphocytosis. So that will actually but if it is, for example, a lot of eosinophils are raised, there may be a parasitic infection which may be indolently going on, and this may be actually creating, the patient may be presenting with the symptoms of a parasitic infection as well. So once we've done our laboratory values like blood CP, ESR, CRP, then we have to go for the radiographic evidence. Once we have gone for the radiographic evidence, the first and foremost is always the X-rays of the spine, depending upon whether it is the symptoms involving the cervical spine, thoracic spine, or lumbar spine. So you get an AP and lateral view of all the, depending upon the region of the spine involved. And then you assess it for, once we have assessed for the X-rays, then we may get a clue over there, and the X-rays may be normal as well if there is a very initial stages. Therefore, we may have to go for some form of a MRI as well, so that we have to rule out whether there is any underlying abscess formation or not. And once that is done, we need to get cultures as well, because if we have identified the funding organism, then we can start the antibiotics according to the culture and sensitivity. So imaging could be simple X-rays, could be simply MRI, or once we have identified the abscess, it may be very deep seated. So instead of going for some form of surgery and taking out the abscess, we can go for CT guided biopsy, and once we have identified the organism, then we can go plan the surgery further as well. So all these modality involving the X-rays, MRI, and CT has to be kept in mind, because they may be helpful in reaching the diagnosis. Now, once we have identified whether it's pyogenic or it's non-pyogenic, then how do they actually present? If it's pyogenic, there are different types of pyogenic infection as well. This could be spondylodiscitis, in which it actually there's a degeneration of the vertebral column, as spondylosis is, and discitis means inflammation of the disc space as well. Now, usually the foremost criteria to differentiate from pyogenic and non-pyogenic is that usually the TB does not involve the disc space. It spares the disc space and involves morely the multi-level contiguous segments anterior to the vertebral body, but it spares the disc space. As compared to pyogenic, the pyogenic infection usually involves the discitis. The discitis is very prominent, and that is the major portion of the infection. The other could be the post-procedural discitis. Now, it could be isolated only disc space as well. The vertebral bodies may be spared, but if you look at the MRI, you would see there would be loss of disc space, or actually the disc would be probably gone between the two vertebral segments. Or it could be pyogenic spondylitis, that is, there may be disc may be involved, but mainly the degeneration of the vertebral have actually resulted in form of a degenerative changes of the vertebral body due to infection. If you see what are the clinical features of acute pyogenic infection, usually if it is involving the cervical spine, may present with neck pain. There could be, as it is acute, it may be resulting with severe muscle spasm. There may be stiffness, as it may due to patient may be having a problem with the movement, especially the flexion and extension and lateral bending. And there may be neck movements may be highly restricted and quite painful as well. Usually abscess formation is rare, but once if that does forms, that is very much visible on the MRI as well. So if you get in, once your patient presents with these kind of symptoms and you're suspecting some form of acute pyogenic vertebral osteomyelitis, one must get blood CP, ESR, and CRP. Once CRP would be raised, ESR would be raised, there would be definitely TLC count would be high, and with increased neutrophilic count as well on the blood CP report. Then you get an X-rays. If you see it over here, probably this does not really shows much evidence, except there's mild loss of disc space over at the C6, C7 level. But if this patient has progressed to to loss of spondylodiscitis. That is, there is the degenerative spine disease leading to kind of a collapse of the vertebra. There is a complete loss of disc space as well as anteriorly as well as posteriorly, and it actually started to involve both the upper and the lower vertebra. Now, if you get an MRI of these kind of a patient, this is usually the kind of a picture you see. If you see clearly over here, can you appreciate that this is the above vertebra which has actually degenerated? This is the below one, and you cannot appreciate any disc between these two vertebra. And then the disc of the 2-3 vertebra above and below are actually spared, but the disc between the two vertebra where the problem is actually lost. This is another form. If you see it over here, it's actually involving the anterior, middle as well as the posterior column. There is actually the discitis has resulted in the loss of disc space, and you cannot appreciate actually the disc space at all. Now remember these MRI, because when we'll be discussing the non-pyogenic type, especially the tuberculosis, you will appreciate that in tuberculosis the disc space is always preserved. There is abscess which goes like anteriorly, involves multiple columns. It goes above and below. It involves the vertebral body, but it usually spares the discs. That is why how we differentiate on an MRI between a pyogenic and non-pyogenic infection. Now, if you go for the treatment, then what is the treatment? Depending upon, once we have done the laboratory investigations, we have done the ESR, we know what is our culture sensitivity report, we know what is an offending organism. If there is no abscess, then we can go for certain conservative treatment as well, starting with antibiotic therapy as well as the rest. Why we need to rest the patient? Because patient will have a spasm, therefore increase the pain as well. Then certain non-operative treatments like immobilization by traction. For example, in case of cervical spine, we have to apply hollow traction. Or for example, pyogenic infection involving the cervical spine can also be dealt with the use of hard collar as well. By the time patient gets, there is no neurological compromise, there is no progressive loss of neurology, and patient is getting better, patient can be treated conservatively with IV antibiotics only as well. But if there is a progressive loss of neurology, or if there is a neurological compromise, and we are suspecting that actually the collapse has resulted in severe form of a spinal stenosis, then we may have to go for some form of a surgical decompression. And that is also true when there is an abscess formation as well. If abscess is there, it will not get resolved by use of antibiotics. We have to go in and drain that. And decompression could be simply debridement and drainage, that you go in from the bag, you debride it out and come out without doing any other fixation or stabilization procedure. Or it could be you go in there, you debride everything out, you drain the abscess, and once you have drained the abscess, you drain the necrotic dead tissue out as well, and then you stabilize the spine, because otherwise the collapse would result in more form of a neurological compromise. So then the other options is that using a bone strut or bone graft and using posterior anterior instrumentation to actually stabilize the spine. Now coming to the non-pyogenic form, that is the spinal tuberculosis. Among the non-pyogenic, as I told you, there are multiple other offending organisms like brucellosis, aspergillus, fungal infection, parasitic infection, but they're usually very less common. The most common actually is that there's been now, previous in few years, there has been resurgence of tuberculosis in the different parts of the US and UK as well, and that is why, because patients have become immunocompromised due to HIV. Therefore, these patients, especially with HIV, are especially susceptible to spinal tuberculosis despite not being part of the endemic areas. Now, if you see, this is a normal spine. The reason I'm trying to convince you is over here that this is the vertebral body. This is a disc in between, and you can appreciate the posterior ligamentous complex as well as present over there. What happens is the infection usually starts anteriorly, and if you look closely, it's actually lifting of the anterior longitudinal ligament ALL, but it's sparing the discs. This is where the difference between the tuberculosis and pyogenic is the main difference. Usually, most of the time it's spared, but not always, but most of the time it does spares the disc, and it actually spreads to contiguous level above and below. It will spread above, involve this vertebral body, then involve this vertebral body by sparing this discs, or it can go below involving this vertebral body as well as this, but it would spare all these discs in between. Other risk could be that it is less likely, very less small percent of chances it involves a disc in which actually collapse is so much that actually the disc has collapsed between the vertebral body, leading to infection intervertebral disc or discitis. But although this is very rare as compared with the tuberculosis. Now, this is another form of spondylodiscitis with kyphosis. If you appreciate it over here, that this is actually elevation of anterior longitudinal ligament. The abscess, the tuberculous abscess is collected under that. It is increasing in size, and actually this lead involving the vertebral bodies. And the vertebral bodies have become so degenerated due to infection that eventually there is a collapse of this. And this leads to kyphosis and increased kyphosis or gibbous deformity, which is classically seen with the tuberculosis of the thoracic spine. Now coming to the clinical features, how would a tuberculous spinal infection look like? As there would be definitely some form of neck pain, but usually it has a chronic sequelae. There is actually long history. Patient may be having low back pain, neck pain from last 4 to 6 months, maybe a year as well. And patient may have off and on exacerbations as well, maybe increased neck pain some days, and there may be decreased neck pain as well. There may be associated weight loss, malaise, night sweats as well, along with the stiffness, which may be not excessive, but there will be some form of stiffness associated with the muscle spasm as well. The problem with, as this tuberculous infections affect other joints as well, there may be difficulty in swallowing, there may be tenderness, and the foremost sign is always the kyphosis. The patient will complain of that actually his thoracic spine is going into some form of kyphosis. Although normal kyphotic angle of a thoracic spine is 20 to 40 degree, but when you measure the kyphotic angle, it actually has increased to more greater than 60 degree of the kyphosis. This means that actually the spine is going into progressive kyphosis at the thoracic level. Fluctuant abscess in the neck, this may be present as well. Why? Because there may be a formation of abscess over there as well, and there may be retropharyngeal abscesses which may impede with the swelling as well. And usually tuberculous patients, there is increased chances of abscess formation outside the spine as well. So if you see on a physical examination, the foremost would be the kyphotic deformity. As with any history and examination, you have to look at all of the neurological compromises as well. This may be associated with different loss of reflexes as well. So you have to assess the patient as a whole. And there may be associated neurological deficit. And neurological deficit may be due to the increased kyphosis, or there may be involvement at some other level as well. Now, if you get an imaging, once you get X-rays, if you see it over here, this is the cervicothoracic junction, and you can appreciate how much kyphosis actually started to occur of this patient. Similarly, if you see that over here, this is a thoracolumbar junction, you can appreciate how many vertebrae, 1, 2, 3, 4, 5 or 6 vertebrae are actually involved into this kyphotic deformity. This is called as gibbous, in which there is a severe kyphotic deformity and multiple vertebral bodies are actually lost in this sort of a situation. This is as another view of this, the same thing, and you can appreciate how much vertebral bodies have been involved. And when there is an end stage, it almost erodes everything. It erodes vertebral bodies, it erodes intervertebral disc. But usually that's where we differentiate. Initially, the discs are always spared in tuberculosis as compared to the pyogenic infection. Now, treatment, if it's picked up early, we may have to go for some form of CS. We have to go for ZN staining of these organisms. And usually on slides you can appreciate there are red snappers against the blue background. These are classical mycobacterium tuberculosis are classically seen on the histopathology slide like this. And once we have identified this, we can go for the medical management as well. Now, medical management starts with the 4 drugs initially. That is the isoniazid, rifampicin, or rifampin, ethambutol, and pyrazinamide. All these 4 drugs are given for 2 months initially, and then isoniazid and rifampin is continued for 9 to 18 months maybe. Sometimes maybe 18 months maybe they have to be continued so that the patient is actually cleared of the spinal infection, because spinal infections are very deep-seated, and once they develop, it's very hard to go by. So you will have to take anti-tuberculous medication therapy for a very prolonged period of time. Now, initial treatment, if patient is developing progressive neural collapse, there is progressive loss of neurology, for example, in form of there may be paraplegia or diplegia may be present as well. Then we can, initial treatment could be, if it's involving the cervical spine, could be form of spinal orthosis. That is actually so that the cervical spine does not goes into excessive kyphosis. Hard collar can be used so that the patient does not develop excessive kyphosis, leading to cervical spine involvement, and eventually which may develop into quadriplegia as well. Other operative indications, which may include multiple surgeries, such as it could be hollow traction as well. If hollow traction is used, it is actually to decompress the spine so that the excessive kyphosis can be prevented, especially the cervical spine. Then there could be anterior decompression. As I told you in the previous slides, as well as in the previous photos you've seen, that actually it involves mainly under the anterior longitudinal ligament. So when we are doing the debridement, we don't have to just go from posteriorly, we have to go from anteriorly as well. And we have to remove all the abscess which is present under the anterior longitudinal ligament, and that removal actually helps in the otherwise there will be incomplete debridement and infection would stay over there. And once we have actually removed a lot of bone anteriorly as well as in the middle column as well as the posteriorly, then usually most of the time the spine is unstable. So when there is unstable, you have to go for some form of a grafting, which could be in form of bone grafting in cage construct, or could be some form of a vascular graft can be used, and such as cortical graft can be used to stabilize the spine, and so that it does not goes in kyphosis once the surgery is done. And then it could the anterior plating as well as the posterior instrumentation may be required as well, because usually there is multiple contagious levels, and once we have removed all the debridement, there's a lot of instability in the spine. So not only you have to put graft anteriorly, you have to put plate anteriorly as well to stabilize the remaining vertebra, as well as you have to put some form of instrumentation posteriorly as well, so that the spine remains stable enough and does not lead to collapse and kyphotic deformity. Now, different operative treatment may be depending upon which level of the cervical spine is involved. If cervical spine is involved, we can go for hollow traction or cervical orthosis in form of hard collar. We may, if there is excessive thoracic kyphosis, we may have to go for some form of spadical subtraction osteotomy. If you see it over here, what they've done is they have removed the pedicles up till now, and they have stabilized posteriorly the spine so that it does not goes into kyphosis once the pedicles have been removed. And that is how they have stabilized it, so that although the range of motion of the joint would be lost, but definitely the stabilization procedures are needed, so that once we have done the debridement and moved the tender necrotic tissue, the spine does not goes into further kyphosis and may eventually lead to complete neurological or spinal cord injury. Other option could be in case of if it is involving the thoracic kyphosis, and this due to we have start of the anti-tuberculous medicines, if it has healed over time and it's only actually the spine of thoracic spine has become more rigid due to maybe producing focal neurological loss, then we can go for this sort of treatment called as direct compression internal kyphectomy, in which actually the spinal cord is moved more anteriorly, and you do not correct the kyphosis much because now the infection is healed out, but this actually decompresses the spinal cord morely. Then comes other techniques such as different surgical techniques may be visible, as well as I told you that you have to go for anterior decompression and corpectomy, plus minus stratigrafting or posterior instrumentation or stabilization plus posterior column shortening. Now there's a multiple list what to do and what not to do, but to understand it in a simple manner, what you need to understand is that tuberculosis involving the anterior column, it involves the middle as well as sometimes the posterior, but mostly it involves the anterior middle column. So if you're doing debridement anteriorly and you're taking off a lot of bone from there, and all the debrided necrotic tissue is gone, Once if you will leave that as such, this will lead to anterior collapse, and this anterior collapse will lead to increased kyphosis. So once increased kyphosis happen, that would put a lot of strain on the posterior ligamentous complex. Therefore, either they would rupture and there would be translation of the vertebra, or this would actually create more problems and increased kyphosis would be there. So to balance the spine, what you need to understand is if you're taking a lot of debridement of has been done from anteriorly, because there is a lot of abscess over there, there's a lot of necrotic material over there, then you have to stabilize the spine not only anteriorly as well as posteriorly, because otherwise putting excess strain on any of the column, either anterior, middle or posterior, this would actually increase the degenerative process, because the patient is already under stress due to infection, patient is already under stress due to surgery, and once post-surgical recovery is, and there is a lot of stress on any one of the column, that column will actually lead to more degeneration and collapse and eventually create more problem for you. So for your surgery to be successful, you need to understand that yes, you need to take out infection, you need to do all the debridement, you need to take out all the necrotic tissue out, but you need to stabilize the spine good enough so that post-operatively the recovery of the patient is good enough and there is no collapse of any of the column. So this is actually what I'm talking about. This is the anterior column, this involves the middle, and this involves the posterior column. Anterior column by definition is anterior 2/3 of the vertebral body and anterior longitudinal ligament. Middle column is posterior 1/3 of the vertebral body and posterior longitudinal ligament. And all this involving the lamina, ligamentum flavum, interspinous ligament, intraspinous transverse ligaments, all these come in the posterior column. So if you have taken out this wedge, or if you have taken out, as this is actually collapsing in a wedge and increased kyphosis, if you have taken out everything from here, what do you expect? Wouldn't this more collapse like this if there is no stabilization procedure? So if it's going to collapse like this, there will definitely translation of this vertebra over the top of this. This would further create more problem at this level, because the spinal cord width or the volume would be reduced, and this will produce some form of a listhesis. So to understand that, you have to understand that once we have done the debridement, you have to stabilize both anteriorly as well as posteriorly. And to do that, this is what they do. They, instead of making this side of a wedge, they make it a square. Now how they have made it a square, they have taken out all the debrided tissue and stabilized posteriorly in form of a something to, so that the posterior column can get support enough and the spine does not collapse over here. But sometimes this is not enough, because this thing would actually put more strain on these bars which has been used to stabilize the posterior column. So to offload them, you have to do something to stabilize the anterior column as well. So for that, you have to use an anterior plate. Along with this, space cannot be left empty, so you have to use some form of graft as well. Now graft could be in form of a cage construct in which the graft is being put, or a simple some form of a longitudinal cortical graft can be utilized as well. If you see it over here, this is exactly they have done. They have posteriorly fixed it. Anteriorly, they have put a cage or a graft which is actually fixed with a metallic cylinder which has been placed, and in with that you put a lot of bone graft so that the bony union occurs. Now this is actually going to help, that it's not going to not only put decreased stress on the posterior column, but will also not allow the collapse of the anterior column. So therefore there will be no kyphosis post-operatively, there will be no collapse, and there will be no increased strain on the posterior column as well, and you will get a good recovery, and the patient will recover very well from the surgery, like this form. Now if you see it, this is another way of doing it as well. Instead of putting a cage in, you can put two bars anteriorly, and you can put the bone graft as well. But the important point is over here is that whatever the way you choose, you have to stabilize the anterior column, you have to stabilize the posterior column along with the anterior strut grafting, because that is the mainstay of the treatment. Otherwise, if any of the column is left, the column which is actually taking the load will eventually collapse, and patient will not have a very good recovery. And once that happens, or these kyphosis happens, or listhesis, or slippage of the vertebra occurs, this may predispose patient towards a complete spinal cord injury as well. Now, complications of the spinal tuberculosis. Complications could be the patient may have healed tuberculosis, but actually the collapse has resulted in increased kyphotic deformity because anteriorly the bone was lost. The fibrotic material has formed, but that fibrotic material is not good enough to support the spine. Therefore, increased kyphosis or gibbous formation is one of the very important complications of the in spinal tuberculosis. Due to retropharyngeal abscess, there still may be difficulty swallowing or hoarseness, which may involve the retropharyngeal nerve. There may be TB arteritis or pseudoaneurysm when this tuberculous infective organism involves mainly the vessels around the spinal cord. There may be respiratory compromise, there may be increased infection, loss, there may be associated bronchiectasis as well, or the most commonly the sinus formation because the patient is immunocompromised. Patient does not heal well, and this may result in a sinus which is actually maybe communicating with the metal plate, and that is kind of a disaster you can expect. And you have put in a very good work, you put in TA plate posteriorly, you put a graft in, and after 4 months, 6 months time, you see the patient is complaining, oh, there is something coming out of my back, and then you see a sinus discharge which is actually communicating with your hardware. That's unfortunately a disaster which can happen, but this is definitely possible. Why? Because these patients are actually immunocompromised and their wound healing ability is not that of a normal person, so they have to be counseled properly as well, that they need to take their diet well, they need to increase their immunity levels. Another could be POTS paraplegia. The collapse may be so much that this may lead to neurological injury or complete neurological loss, which is called as the POTS paraplegia, because the spinal tuberculosis is also called as POTS disease. Now, the atypical spinal tuberculosis, although most commonly usually involves the tuberculosis involves the mainly these mycobacterium. Tuberculosis is the most common offending organism, but there are other mycobacteria as well which may be involving the spine, and they usually call atypical sort of a tuberculosis infection. And for them, you may not need that kind of an extensive surgery because they do not actually cause abscesses or they do not cause the complete kyphostic deformity or loss of vertebral height actually. Usually, if for example they are impinging a single nerve root at central level, you may only require a laminectomy as well. But what is we need to remember over here is, if you are performing a laminectomy or 1 or 2 levels, that's something else. But what you need to assess is if you have to perform a laminectomy on multiple levels, then actually you're creating spinal deformity or instability as well. So you have to stabilize the spine with either anteriorly or posteriorly with some instrumentation as well. So in atypical forms, what's more important is that yes, you need to get rid of the infection, but you need to make it sure that you keep the spine stable. If your multiple laminectomy is actually making spine unstable, then you need to fix the spine as well to make it stable. Otherwise, that will actually be more disaster for the patient. Patient was not kyphotic initially, but after surgery, patient will develop kyphosis, eventually will develop somehow a neurological injury. Now, other options could be decompression and myelotomy. Now, if you see it over here, if there is so much canal compromise, and this is actually occurring due to bony spur or this deformity or infection which is actually occurred over here, then you need to do the decompression of the foramina, and myelotomy may be done as well, so that the foraminas are which have been narrowed due to bony spurs, they can then size can be increased, and so the nerve which is exiting out can be restored as well. Usually this is very rarely done, these two procedures, because atypical spinal tuberculosis infection is very rare as well. But what we need to understand is that when we're doing this form of surgery, foraminotomies and myelotomies as well as the laminotomies, what we need to understand is that we do not make the spine unstable. Making it unstable would actually increase the problems for the patients, and later on patient may present with a neurological compromise. We have discussed mainly the spinal infections. Broadly, they can be classified into two forms. One is the pyogenic and the non-pyogenic, and among the non-pyogenic, the most common is tuberculosis. Although less commonly, it can involve fungal, parasitic, brucellosis, aspergillus as well. Among the pyogenic, the most common is the staph organism. Among that is aureus of staph epidermis. Less commonly, Pseudomonas may also be common in IV drug abusers, and patients with sickle cell disease may have Salmonella spinal infections as well. Broadly, whenever we get a patient with spinal infection, we classify into what is the history of the patient, and what is the examination. On history, we have to look out for whether it is acute or chronic, whether it is associated with backache, low back pain, stiffness, muscle spasm, decreased range of motion of the spinal cord or not, and whether it is associated with some form of malaise or not. Once we have defined it, most likely whether it is acute pyogenic vertebral osteomyelitis or it's going towards the chronic tuberculous osteomyelitis, then we have to get a blood CP, ESR, and CRP as well. We have to look at the TLC levels. We have to look whether the neutrophils are raised, leukocytosis is there, and we have to look at the values of ESR and CRP as well. Rarely, in this case for parasitic infection, there is raised eosinophils as well. So when you are doing the CP, you have to look at that as well. Although there is a very less chance of it having a parasitic spinal infection. Once you've done that, then we move towards from laboratory findings, we move to the radiological assessments. Radiological assessments always involve the X-rays first, AP and lateral view of the spine, depending upon which level is involved. Then we have to go for MRI. For MRI, what we look at is whether there is how much kyphosis is there, how much canal compromise is there, and whether there is a progressive neurological loss or not. And among the examination, we have to look at these progressive neurology loss or loss of canal compromise, and we have to look whether the patient is developing neurological symptoms or not. Then we decide whether we have to go for conservative or operative. Usually, initially treatment, once we've done the CS, if it's pyogenic, we start with antibiotic therapy. If it's tuberculosis, we can start with anti-tuberculous therapy. But if the patient is developing neurological compromise or there is progressive paraplegia or loss of neurology, then we have to go for some form of surgical fixation. Now, surgical fixation, once we have done all the debridement, remove the necrotic tissue, the only take-home message is that we operatively a surgeon has to decide whether the spine is stable or not. If it's not stable, then we have to put an anterior plate, strut graft along with the bone graft, as well as posterior fixation, whether it's tuberculous or pyogenic. But sometimes the spine is stable, there's mild infection in a focal area of involvement, then we may have to go for, in case if it's atypical spinal tuberculosis, we may have to go for some form of a laminectomy, foraminotomy or myelotomy as well. Thank you very much. Keep watching sqadia.com.